This is how we do it right here. Freaking got some good movie playing. Got some breakfast.
Hello,
Got some
and
good old
welcome.
brekkie.
Dr. Keith Fader from the West Coast Center for Orthopedic Surgery and Sports Medicine in Manhattan Beach, California. Presently, I'm the chairman of the Department of Orthopedic Surgery at Centinela Hospital. Today, I'll be demonstrating the technique I use to perform arthroscopic osteochondral autogenous transfer, or the OATS procedure.
Add some cool visual effects.
To the serious athlete, a significant post-traumatic defect in the articular cartilage is a devastating injury associated with severe pain, diminished quality of life, as well as the inability to perform at an elite level. Intervention is necessary to relieve the patient's pain, prevent further degenerative changes, and restore the mechanical properties of the joint so that the patient may resume his or her normal level of activity. Unfortunately, articular cartilage demonstrates poor healing capacity and self-repair is unlikely. If the chondral lesion remains symptomatic and does not improve with aggressive conservative treatment, osteochondral autograft transfer is an excellent treatment option. By performing the procedure arthroscopically, we can avoid the debilitating effects associated with open surgery. Injuries to the articular cartilage are, of course, painful events. When a patient first presents to the office with a symptomatic injury, we treat with a COX-2 inhibitor for pain and inflammation. With advanced pain, we use a multimodal approach by supplementing with a non-narcotic and, if necessary, a narcotic pain reliever. By prescribing COX-2 inhibitors early in the treatment, we can limit the pain and disability caused by ongoing inflammation. This allows the physician to get the patient immediately into an aggressive conservative treatment program that includes a COX-2 inhibitor, physical therapy, as well as activity modification and bracing as indicated, so we can hopefully avoid surgical intervention. We keep the patient on COX-2 inhibitors because of their lack of effect on platelet function. As a result, we don't see any increase in bleeding.
I don't really know what's the best way to...
This patient is a 40-year-old elite recreational athlete. The x-ray here of the right knee shows good maintenance of valgus alignment. That's critically important for this particular patient. If this patient did not have good valgus alignment, instead of only doing the osteochondral autograft transfer or OATS procedure, we would have to combine this with a high tibial osteotomy to unload that medial compartment. Specifically in this patient, because of her medial compartment, ongoing pain and disability, the osteochondral autograft transfer is definitively indicated.
Definitively indicated!
The osteochondral lesion of the medial femoral condyle. This is the reason that she has so much recalcitrant.
Yo, where was that phone from?
Pain and disability and medial joint line pain. On the sagittal section, we see the medial femoral condyle,
Zoom in.
lesion, the fluid between the articular surface and the underlying bone, and the separation of the chondral lesion. In addition, we see underlying edema of the bone. And here we are in the medial compartment, and she definitely has a chondral lesion.
This lesion is amenable to an OATS procedure. The osteochondral autograft transfer will provide definitive treatment for the symptomatic, full-thickness chondral lesion of the medial femoral condyle. We always begin with a full diagnostic arthroscopy.
Here we're in the lateral compartment.
We first debride the hypertrophic synovium to allow full visualization of the lateral compartment. Here we have a small middle 1/3 meniscus tear on the leading edge of the lateral meniscus.
And the straight biter.
We will begin the partial meniscectomy with a meniscal basket. We'll follow this up utilizing the homeomiag laser to further smooth and stabilize the leading edge of the lateral meniscus. It's important to point out that there is good preservation of the articular surface of the lateral compartment.
Getting a visualization of the lesion is the number one issue right now. We're just going to use an ablation device to ablate the hypertrophic synovium. The time we invest now is time saved later. It's very important because you can get hung up in all this soft tissue, bringing the graft in, harvesting as well as implanting. And this is something that can't be more emphasized. Hemostasis as well is very important. We will put the tourniquet up at the time of when we start harvesting the grafts and implanting, but if we don't have good hemostasis and good visualization, this procedure is not going to be successful. Okay, now we can actually visualize the lesion. Let's get a probe in here and see the extent of it.
This is a significant chondral lesion of the medial femoral condyle. The lesion is approximately 2.5 centimeters by 1.5 centimeters in size. This larger size lesion is at the outer limits of the capabilities of an osteochondral autograft transfer.
We're going to get rid of this loose cartilage and then do the remainder of our diagnostic scope. It's important to delineate the loose from the intact cartilage, and here we have to, on a moderately aggressive fashion, debride the edges of the lesion to really be sure that we've removed all the unstable cartilage.
We have now completed debridement of the chondral lesion and removal of the unstable cartilage fragments.
Okay, we're going to get our first idea about how large this lesion is.
We are now introducing an 8mm OAT sizing device. This will allow us to approximate the number of osteochondral autograft plugs that will be necessary to fill the lesion. Based on what we're seeing here, it will require 4 to 5 osteochondral autograft plugs to fill the lesion. Based on the large number of plugs, it will be necessary to harvest from both the intercolumnar notch, the lateral aspect, as well as the superior lateral femoral condyle.
Okay, good. Let's harvest. We're just continuing to debride the fat pad and hypertrophic synovium so we get a complete visualization of the intercolumnar notch. We've found that using the intercolumnar notch as our donor area has not had any deleterious effects postoperatively, any increased patellofemoral symptoms or patellofemoral sequelae. The next very important step to the harvesting is localization and to get the angle, the appropriate angle into the intercolumnar notch to get a perpendicular approach to the articular cartilage to get the most even plug that you can obtain. Let me just stick. And again, it's really important to debride all the fat pad and hypertrophic synovium because this is what's going to hang us up, getting in and out of the joint. I like to harvest the larger donor plug in the superior portion of the intercolumnar notch. For an 8 recipient, we're actually harvesting a 9 donor. You need to be able to see the markings on the cylinder of the harvesting device. We take a 15mm deep donor plug. Make sure that you're perpendicular to the articular surface and there's no tension on the harvester. Good. A little more, a couple more taps. Okay, one more tap. Good. We're right at 15.
We then make a rapid clockwise and counterclockwise rotation to safely remove the plug.
Rapid.
So we have a good harvest for the 8mm. Now we're going to take the 7mm next. Again, we're pretty well perpendicular. Again, we're going to take a 15mm deep plug. Good. Sure.
We will move to the superior lateral femoral condyle to harvest the remaining plugs.
So we have to do a accessory portal to get the exact angle we need to get to the recipient area of the lesion. We want to make sure we don't do any damage to the meniscus. This is the 8 recipient. So remember, perpendicular is the key here. We're nicely perpendicular to articular surface. Bone's a little bit sclerotic. Good right there. One more tap. Good. We've taken out the recipient plug, 15mm deep, 8mm wide. Yeah. Always want to use the dilator. That comes along with the Arthrex OAT instrumentation. We've now dilated it. We do it manually. And now we'll implant the donor plug. Okay, now we seated the donor and we're sliding it in.
Even when using a dilator, the socket on occasion will remain tight. Care must be taken to avoid damage to the plug on insertion. To ensure proper final placement of the osteochondral autograft plug, we like to leave the plug slightly proud and gently utilize an impactor to fine-tune.
So now we're going to do the seventh recipient. We're going to go flush against the other plug. Go ahead. 15 millimeters deep again. Yep. Okay. So we've dilated to 15. Now we'll take the donor. What we're looking at is the shape of the plug.
Most often, the articular portion of the osteochondral plug is not completely flat. We must assess the high side and the low side and the corresponding mark on the harvest cylinder. Here, the number 2 mark is the low side of the osteochondral articular surface. We place this on the periphery of the lesion.
Okay, good. Good. We're going to fine tune this one as well.
Wrong whole food. Don't be a menace.
It's pretty good. Okay. Plug number 2 has been put in. Let me see the size. So after each subsequent plug, we want to resize to harvest the appropriate donor. Harvesting from the superior lateral portal is a little more difficult than taking it from the notch. You have to immediately move the patella slightly, get direct access in a perpendicular fashion.
Remember, it is critical to have an experienced orthopedic assistant to assure proper visualization as well as perpendicular placement of the harvest device.
Okay, right there. We're going to make a second accessory portal to get the additional 2 superolateral plugs.
The superior lateral femoral harvest can also be done under direct vision with a mini arthrotomy.
Yep, now.
It is important to carry out the superior lateral femoral harvest as superior and lateral as possible to prevent later patellofemoral problems.
Ready? Yep. All right, so now we've completed our harvest superior laterally, the far superior lateral portion of the femur and lateral femoral condyle. Good. Good.
That looks like the knee of an elite
We just
recreational
harvested
athlete.
the recipient socket for the 6 millimeter osteochondral plug. Now we're going to place it. So this is a 6 millimeter donor, and we're going to use the dilator. Good. We go 15 millimeters deep. Now we're going to put the 6 millimeter donor plug in.
Always proceed in a stepwise fashion as follows. Assess and measure the lesion, harvest the donor, harvest the recipient, dilate the recipient socket, implant the donor, fine-tune the placement of the donor.
Just that. Nice. So the 6 millimeter plug is seated. We're going to go to 5 millimeters now. Good. Good. Dilate to 15. Okay, I'm going to back out to this balloon. Keep going. Turn. Okay, good. Last plug coming up. Yep. Very good, yep. Just a tap, one tap on the top. Gary. Yeah, just. Good. Nice. Well, we've now completed our osteochondral autograft transfer. We've recreated the articular surface of the medial femoral condyle and in a radius of curvature. No impingement. No protruding grafts, but we have reconstituted the articular surface level on the whole periphery of the implant.
Osteochondral autograft transfer at our institution is done arthroscopically and on an outpatient basis instead of open, which may require a hospital stay. Still, there's a good deal of post-op pain, but it's significantly reduced compared to similar open surgery. In the immediate post-operative period, pain is controlled using a multimodal approach, a COX-2 inhibitor given at the highest approved dose, in conjunction with non-narcotic and, if necessary, narcotic pain relievers. Patients are discharged non-weight-bearing on crutches and immediately begin post-operative rehabilitation with initiation of continuous passive motion and straight leg raises. 3 days post-op, they begin hands-on physical therapy to maximize the early return of range of motion, decrease any post-op swelling, and limit disuse muscle atrophy. During this time, they continue to take a COX-2 inhibitor because we want to limit the inflammatory response. In order to limit the pain and swelling in the early post-op period, the patient continues to take a COX-2 inhibitor to limit the inflammatory response. We will maintain the use of a COX-2 inhibitor for up to 4 to 6 weeks post-operatively in order to maximize their participation in rehabilitation. In summary, for symptomatic chondral lesions measuring 2 square centimeters or less, arthroscopic osteochondral autograft transfer is a successful procedure. Having this surgery as part of our surgical armamentarium allows the athlete with what was previously considered a career-ending injury to return to elite-level competition. My experience with this procedure, when indicated, has been very satisfying. I believe that being able to return an otherwise debilitated athlete to elite-level competition is the goal of the sports medicine physician.
Blech, sports medicine. Blech. Blech.